next, I know they're a little bit behind, but next is my great pleasure again to introduce one of my very dear friends, Monica Jones, who is the founder of the Brain Recovery Project. Some of you have already I've actually referred a lot of people to Monica Jones. She is my go-to person for any surgical interventions or any families who are looking to find out what they're up against when we're talking about corpus calcidomies or VNS or RNS. And so she's going to present a little bit about surgical treatments for epilepsy. And she recently had 2 papers published about this from all the data she's been collecting. So I'm really, really pleased to welcome Monica Jones.
There we go. Now I'm unmuted. You would think that after 16 months of this, that we knew what we were doing, but we're still challenged. I hope everyone can hear me. My name is Monica Jones, and I'm the visionary founder of the Brain Recovery Project, Childhood Epilepsy Surgery Foundation. We serve the community of children anywhere on the epilepsy surgery journey, whether you're just starting to think about epilepsy surgery, all the way to transitioning into adulthood. We hope you look at our website. We often collaborate with other organizations like Duke 15, Ring 14, and Project 8P, and I'm really very pleased to be here. I started the organization a few years after my son had hemispherectomy surgery, which is removing half the brain. And I've also pictured here 2 kids that had hemispherectomy, removing half the brain, both for infantile spasms when they were quite young. And this is a great pic of them at one of our family conferences, which is a wonderful way to get to know the children. Let's talk a little bit about epilepsy surgery. It is no longer considered a last resort. I hope everyone walks away from this presentation with that in mind. Deciding to have surgical evaluations for your child does not mean that you have decided to have epilepsy surgery for your child. It means you've decided to know all your options. And what I hear from parents so frequently is, oh, we're not going to go there yet. We're not going to go in the direction of brain surgery or VNS or any of these other new neuromodulation devices that they have. Again, deciding to have an evaluation does not mean you've decided that, yes, your child will have surgery. All you've decided is to understand what your options are, to have all the cards on the table before you proceed further. What is epilepsy surgery broadly? It's really 4 different types of things. It's any type of brain surgery or neurosurgery that either removes part of the brain, disconnects part of the brain, destroys part of the brain, or stimulates part of the brain. Most of them require surgery to the brain itself, but there is one, VNS, which is just implanting something on the vagus nerve. So really easy to remember: remove, destroys, disconnects, or stimulated. We all know what the risks of drug-resistant seizures are. I'm not sure I really need to go through that, but you really can't have a lot of seizures in childhood. It can be very dangerous. It can cause development to freeze in time or regress. You can have significant memory impairment. There are side effects to all the drugs that our children take: osteoporosis, kidney stones, severe fatigue. Many of our kids have ongoing liver toxicity. You can have psychiatric dysfunction with ongoing seizures. We know there is a connection between autism and ongoing seizure activity. Some say it's autism, others call it an epileptic encephalopathy. At the end of the day, it's the same thing, where you have this dysfunction of the brain caused by seizures, especially if they begin in infancy or early childhood. We know that the more seizures you have, that can beget even further seizure activity. In unfortunate circumstances, it can cause ongoing seizures can cause brain damage, organ failure, and obviously death if there's a long seizure. And we just had a wonderful presentation about SUDEP, unexplained death in epilepsy, which is something so many of us parents fear. When do you ask for a surgical evaluation? I'm going to kind of fly through this quickly, but the first one is most important, and that's when you've failed 2 medications. Most children are seizure-free after the first drug. About another 13% will be seizure-free after the second drug. But really, after the third drug, your chances of seizure control drop down to almost zero. They're at 4%. And then after that, it's 0%. After failure of 2 appropriate medications, you should ask for a referral for a surgical evaluation. And this always comes as a surprise to so many families because they'll say, doctors continue to throw medications at us, 2, 3, 4, 5. We have so many children in our community who are on 8, 10 different medications or have failed 10 different medications before anyone even mentioned surgery. It's after failure of 2 appropriate medications. In other words, your child is on the right medication for their seizure type. They weren't given phenobarbital, for example, for infantile spasms. We know that's not a frontline drug. But after they've failed 2 frontline drugs, then they should have a surgical evaluation. What does it mean to fail? Well, you fail if you have a febrile seizure, a breakthrough seizure, even an aura. That's considered failing that drug. And in order to have success, you should have no seizures, including no febrile seizures, no breakthroughs, and no auras for at least 3 times the longest prior seizure-free period before you use that drug, or 12 months, whichever is longer. Sorry about that. I'm having trouble with my presentation. The second time you consider whether your child should have epilepsy surgery is if your child has one of the types of epilepsies formerly known as catastrophic epilepsies. And I think for this group, the big one would be infantile spasms, because I believe all 3 of these genetic syndromes that your kids have can have infantile spasms in them. And then many of our kids eventually, if the seizures don't stop, then it can escalate to Lennox-Gastaut syndrome. So again, if you've either failed 2 drugs or your child has been diagnosed with a catastrophic epilepsy, you want to think about epilepsy surgery. And then the third condition, which likely doesn't apply here, although there may be some in your group that have ESES, is if your child has been diagnosed with a condition that's known to be drug resistant. So again, if you failed 2 drugs or diagnosed with a catastrophic epilepsy or have a drug resistant condition, you have to start thinking about epilepsy surgery. Now, what does it mean to have a surgical evaluation? It's really quite straightforward. The first would be what's known as a phase 1, and these are non-invasive assessments. Typically a 5-day EEG. Just know that EEGs are not 100% reliable. You can still have seizures even though your EEG is all clear. And this is especially in cases where seizures come from deeper within the brain. Your child should have an MRI, again, with the caveat that MRIs are not 100% reliable. Very small deformities can be subtle. Some cortical dysplasias can be subtle. And we're going to loop back to this a little bit towards the end, because even some of the genetic epilepsies can have subtle dysplasias associated with them. And you want to make sure you find those, even in cases of genetic epilepsies. Your child should have a MEG. These are tricky because not all facilities have MEGs. They're very expensive. They have to be housed in special buildings. I think there are 7 MEGs in the country, but this is another thing that's part of the phase 1 evaluation would be the MEG. You should have a PET scan with radioactive tracers. These are generally not very precise, but again, the qualified team will know when to use these. SPECT is another type of evaluation that requires a radioactive tracer that increases blood flow, that takes a look at the increased blood flow during a seizure. Your child may have fMRI to see, what part of the brain lights up when performing a task, so that you can assess whether the seizures are coming from, for example, eloquent cortex, and that's parts of the brain that control motor movements or speech. And in some cases, if they're trying to localize whether the seizures are coming from speech areas, they may do something called a WADA test, which requires an injection. that goes into with a tracer that goes into the brain and quiets the brain on one side so that you can know where speech comes from. But except for the injection on the WADA, all of these are non-invasive tests that your child can have so that the team can start to take a look at how the seizures present, what the clinical presentation is of the seizure, and then figure out if they can see where the seizures are starting in the brain. And this is what a PET scan looks like, SPECT scan, MEG. Those of you, if you have a child like my son who may not be able to participate in these types of assessments because maybe they have behavioral challenges, like there's no way my son would sit in a MEG for any extended amount of time. But again, you work with a team that has substantial experience treating kids like yours. They may require some subtle sedation, or they may have, games that they can play or something so that they can be compliant in these machines. I'm just quickly going through this for you. Phase 2 evaluations are invasive, and typically these require opening or drilling a hole in the skull. You can have subdural grids, which are directly placed below the dura onto the brain to see if they can find the seizure focus. You can have depth electrodes, which are long electrodes that go into the brain. Same with stereo EEG, which kind of triangulates where the seizures are coming from in the brain. Not all children are candidates for these. Your team will decide whether you should move on to a phase 2 evaluation. Typically, these are kids with subtle cortical dysplasias or areas where they're really trying to pinpoint a little bit deeper. My son had subdural grids right before his hemispherectomy, sort of in the same surgery, just so they could be 100% sure that the seizures were coming from the left side of his brain, which is in fact where they were coming from. This is what depth electrodes look like. And this is stereo EEG. Typically, they're about between 10 and 20 long depth electrodes that are put in, and the child is evaluated over an extended amount of time to see where the seizures are coming from. You should have this done at a level 4 epilepsy center. You can go to the NAEC's website to find out which centers are qualified to perform these assessments on children. And especially in the cases of infantile spasms, you're going to want a team with substantial experience with epilepsy surgery as well as with imaging. Just because a facility is a level 4 doesn't automatically mean that they're qualified to perform some of the bigger procedures. You have to ask a lot of really difficult questions. It's hard to do in that atmosphere sometimes, but you want to make sure that the surgeon has substantial experience, the anesthesiology has a substantial experience, and that the team in general has been doing this for quite some time. We were very fortunate. Our team was at UCLA and they'd been performing resection since the 80s. And I felt very comfortable having my son there, especially because he had to have surgery so young. Generally, now we talked about the 4 different types of epilepsy surgeries, and these can be categorized, all 4 of them, into 2 different subtypes, which are those that are intended to be 100% curative. That's the end goal, and those are between 60 and 85% curative in all cases, or those that are palliative, meaning they reduce or stop the spread. Quickly going through this, a lesionectomy is removing just a little piece of the brain. And typically this is done with an open craniotomy and a resection, but a lot of facilities are starting to use laser ablation, which is a heat laser that is into the brain, and they'll destroy part of the brain that way. You can have multiple lobectomies, posterior quadrant resection, removing the back 3 lobes, or like in my son, hemispherectomy, or hemispherotomy, which can be disconnecting or removing half the brain. And some of these surgeries are done combined, so they might resect a little piece, as well as disconnect white matter so the seizures can't propagate. And then you can have a whole host of palliative procedures, which may be more appropriate for this population if the surgeons can't find pieces of the brain to remove. Then you're looking at palliative procedures like corpus callosotomy, multiple subpial transection, VNS, RNS, or deep brain stimulation. Now, corpus callosotomy is cutting the major connections between the left and the right half of the brain. Corpus callosum has about 250 million neurons that connect, neuron fibers that connect the 2 sides. The good news is that you have other connections that go across as well. So this is typically why kids generally do well, especially if they're younger after corpus callosotomy, because those other connections that go across can sort of reorganize in order to, I don't like to say take over all the functions of the corpus callosum, but really kids tend to do a little better if they're younger. If they have this as they're older, they can have things like disconnection syndrome or alien hand. But again, this is a conversation to have with the neurologist to see what their success rate has been. This is kind of a last ditch surgery for kids who have infantile spasms. If they're not candidates for resection or hemispherectomy, then you would have a conversation about whether your child should have a corpus callosotomy. The younger, the better. And now these can be done via laser, just little small holes in the skull to disconnect the corpus callosum. And they're most effective for kids who have drop attacks. So if you have children in your community that have drop attacks, again, I would highly encourage a phase 1 and phase 2 evaluation if appropriate to see if your child is a candidate for a drop attack. Vagus nerve stimulator is the least invasive of the procedures. It's just a stimulator that goes on the neck. I have a feeling most of you out there are familiar with VNS, and this doesn't generally stop the seizures. It can't be targeted for a specific seizure type. It's sort of on a rolling loop to very slowly stop the seizures before they spread. You typically see effects 2 years out after having the VNS implanted. And it's found to be, and there was recently a great published paper about it, it's found to be most successful the sooner you do it after having the seizures. So 4 to 5 years after surgery, after the seizures start is generally where you'll find the most success. The longer you wait to have it implanted, the more that your success rate starts to drop. Responsive neurostimulation is something that we're all quite excited about for the community of children that are not candidates for resection. I know at least one child in your community or in the community of Duke 15Q has had responsive neurostimulation with good success. And what good success means is that the seizures have not stopped completely, but they have been reduced substantially, so much so that the child can now participate in school comfortably. They've seen a reduction in the autistic characteristics that can often go along with epilepsy syndromes. It requires a small craniectomy about the size, I like to say like a really big pack of gum, so that the RNS implant can go into the brain. It does require the skull to be fully formed. But I'm seeing some teams drop down to age 4 with this technology. It's technically only approved for, I think it's down to age 12 at this point, but some teams are going as low as age 4. We also like to think about this as a running EEG. So you download daily what the RNS implant sees in the child's brain and sees in terms of an EEG, and you'll get a really, really clear picture of the amount of seizure activity that's going on. And then it will predict the seizures based on this running data and try to stop them before they start. A lot more teams are starting to use this. I would again encourage, though, a very experienced team, a level 4 team. Sometimes it's not enough. You want to ask them how many implants that they've done. I think that there are some teams that are now over 30 for kids that have had in pediatrics. This has generally been done in older teams and older kids. Sorry about that. And then deep brain stimulation, very common in the world of Parkinson's and is now being used in epilepsy. There are teams with a lot of experience with this in adults, and we're starting to see it in pediatrics. This is a procedure that requires 2 surgeries, and as different than responsive neurostimulation in that the implant rests on the chest and the leads will go typically into the thalamus of the brain, which has been kind of implicated in propagating seizures. So what the deep brain stimulator will do is stop seizures from really spreading before they get too far. So it doesn't stop them completely, but stops them from spreading to the body. Epilepsy surgery for genetic epilepsies is something that we're really starting to talk about more. And you all have kids with genetic epilepsies out there that typically don't have cortical dysplasias or other focal things associated with it. But in this paper, out of a team in France that really has substantial experience with with genetic epilepsies, actually this team is Australia and England primarily, they still encourage an epilepsy surgery evaluation, even if your child has a genetic epilepsy, because at least with SCN1A, they could find a focal point of where the seizures were starting and had some success resecting the part of the brain where the seizures started. Again, this is all generally new when we talk about resection. It's a conversation to have with your experienced team. And again, the phase 1 evaluation, at least, you've not decided if you want to have surgery. You've decided you want to understand all of your child's options. I can take questions if you have time.
Hi, Monica. I just want to thank you for this presentation. You always do such a good job presenting some very difficult and hard to understand sometimes information. We do have a couple of questions from our families here. So
Sure.
one is, what do you consider the younger, the better for the corpus colostomy? So that he's really trying to get at what ages, is it really younger, the better for these kinds of complex surgeries or not?
I think the younger the better is probably the wrong way to say it. The shorter time seizing prior to surgery, we generally see the better outcomes. Not in all cases. There's no hard and fast rule, but I think this community knows more than anyone is that when you have seizures in infancy, when you have seizures in early childhood, they can disrupt neural circuits so much so that you're going to see in the long run a really difficult progression in terms of the overall outcomes of the child. We like to say that the goal has to be to stop those seizures as soon as possible. We don't have hard data on it, especially in terms of infantile spasms. We're glad teams are trying it because we know how catastrophic infantile spasms can be if they last too long. And so it's really more the rule of as soon as possible when you know your child is drug resistant is when to think about it. At least start the process of evaluating.
Am I on? We've got one more question and then we're going to have to move on to our next speaker. But the question is, does the corpus colostomy affect cognition or physical functions?
There are, in the research paper, it says that parents generally don't notice the cognitive challenges that a child would have with a corpus callosotomy. And again, remember, these are children who've had a history of drug-resistant seizures. It's not a child who's responsive to medication. Those changes are generally best picked up in a neuropsychological assessment. They may have trouble planning motor movements, for example, but remember I said there are other interhemispheric connections. I think there are another 6 or so that are much smaller. But again, the younger the child has the corpus callosotomy, we see less of those challenges. The number one thing on my list of things to do right now is to update our corpus callosotomy page so I can get all of this information out there, and I will share it with Duke 15, Project 8P, and Ring 14 so that you all can share with your communities, and we'll kind of drill down on these numbers on how soon you should have it, as well as what are the motor functions and cognitive challenges. I would just say to the parents, remember what the cognitive challenges are associated with a lifetime of seizures. They're a lot, and it's a very heavy burden for our children.
Yes, thank you. We do have a request for your slides, Monica, and so I'm not sure, but I'm sure that we can handle that in some way. So I really, please thank Monica for her time here today and her talk.
Thank you. I'm sorry I couldn't be there in person.
Thank you, Monica. Thank you so much.
Bye-bye.
Bye-bye. So our next speaker today